Okay, well, so we'll start a few lectures discussing coronary artery imaging. So we'll talk about the anatomy of the coronary arteries and what you need to know. Very easy way to think about this is what's called the circle and the half loop model. So if you think of the different views here, so this is a left anterior oblique view, this is a right anterior oblique view. So on this left anterior oblique view, you have the LAD coming towards you, the PDA here also posteriorly. So the LAD runs along the anterior interventricular groove, the PDA runs in the posterior interventricular groove. And in the right atrioventricular groove, you have the right coronary artery, and in the left atrioventricular groove, you have the left circumflex coronary artery. So that's a very simplified approach to the anatomy. Then on the right anterior oblique view, you get the LAD and the PDA in profile like that. So this is a left anterior oblique view here on a volume rendering from a cardiac CT, and we can see that the LAD here comes right towards you in the interventricular groove between the right ventricle and the left ventricle. And then this part of the heart is called the acute margin because the coronary artery here makes an acute angle, and this was named based on the angiographic appearance of that. And then this part is called the obtuse margin of the heart, and the circumflex coronary artery here makes an obtuse angle as it goes around there. So that's where we get, acute marginals versus obtuse marginal branches. That's where that nomenclature comes from. So let's do this here.
I could take it.
What's that?
I thought you were asking.
So vessel A, vessel B. What is vessel A? What is vessel B?
A is conus, B is SA nodal.
Yeah, so vessel A here is the conus branch. So this guy over here is going to be what?
Right.
Yeah, so that's the right coronary artery, that's the RCA. And so the conus branch here is the branch that goes anteriorly towards the outflow tract of the right ventricle. And then this vessel here going back is
SA nodal.
the SA nodal branch, right. So a vessel going posteriorly like that or going into the interatrial septum, right? So that's going to be the SA nodal branch. Remember that the SA node lives in the interatrial septum. So a branch going into the interatrial septum, like you see here, will be the SA nodal branch. So what is the significance of the conus branch in the setting of obstructive coronary artery disease?
It forms an anastomosis with the LAD.
Yeah, so if there's obstruction of the proximal LAD, this can provide a collateral pathway. It actually has a name. What's the name?
Circle of Lucens.
Vicens, right. The circle of Vicens is that collateral pathway, right? From the conus branch to the LAD, if there's obstruction of the proximal LAD. The SA nodal artery, the most common vessel to give rise to the SA nodal artery is the
RCA.
Right. But in about 40% of the time, it will come off the left side of the circulation too, right? So although in most cases it comes off the RCA, you have to be aware that there's a significant percentage of the time where it will come off the left circulation. The vessels that supply the right ventricular myocardium, we call those, remember we went through
RCA, acute marginal.
those branches that come off the RCA, what do we call those? Acute marginals, right, okay. And then what determines the dominant coronary artery? What determines dominance?
Where the PDA branches off?
Yeah, so two things. So the branch that gives you the supply to the PDA, also the posterior or inferior wall of the left ventricle, so the posterior left ventricular branches. So you look at those two to determine the dominant, what vessel is the dominant vessel. So the conus branch, so here we're looking at the right coronary artery here. So the conus branch is the branch that goes anteriorly. We've talked about that. It can be a collateral source to the LAD, which would be over here. And then that collateral pathway is called the circle of Vicens. So about 70% of the time, we'll have the SA nodal artery coming off the right coronary artery that will go posteriorly towards the interatrial septum. Okay? And then we have these branches off the right coronary artery. They're called the acute marginal branches, the largest one, the acute marginal artery. So they supply there the myocardium of the right ventricle. And then when we get to the bottom of the heart, right there behind the posterior surface of the heart there near the diaphragm, that's the crus there. There it will divide into the PDA and the crus artery. So the PDA going this way, the crus artery going that way. Right. And then from that, you will get the AV nodal artery and then branches going to supply the posterior wall, the diaphragmatic wall of the left ventricle in a right dominant system. Okay, so here I've labeled some of these vessels. This is the left main coronary artery. So that can give you the circumflex here, and then here's the LAD coming towards you. So this is the right ventricle here, this is the left ventricle here. So vessel A, what is vessel A, this little guy here?
Septal perforator?
Yeah, so that's a septal perforator that's going down into the interventricular septum. So these septal perforators come off the LAD and they will supply the anterior portion of the interventricular septum. Vessel B, this guy over here,
Diagonal?
that's a diagonal branch, right? So that supplies the anterior wall there of the left ventricle. And then here we have vessel C, this big guy over here. What is that guy?
Ramus?
Yeah, so that's the ramus intermedius. So why do we call that the ramus intermedius? How do you know that's the ramus intermedius?
How do you know it's...
How did you know to call that the ramus intermedius? Not everybody has a ramus intermedius, right?
So the left coronary artery branches into LAD, left circumflex, and...
Yeah, so the left main
Ramus.
usually divides into the LAD and the circumflex, but if you have a trifurcation of the left main, then that vessel in the middle, that's called the ramus intermedius. If there's a trifurcation, then that vessel will be the ramus intermedius. It could take on the supply of a diagonal branch, or it could take on the supply of the obtuse marginal branches. So septal perforators, diagonal, as you said, here you can see one of them is occluded there, and ramus intermedius if there's a trifurcation of the main coronary artery. Okay? All right, so somebody else now. The arrow pointing to this vessel. What is this vessel?
SC node?
Yeah, so what's different about this?
The origin, I don't know, but it looks like the origin's from the
From what?
LAD.
No, this vessel is what?
That's left main.
That's left main. This guy is,
LCX.
yeah. So this guy here is
LAD.
LAD, so this guy would be circumflex, right. So in this case, this is one of those cases where the SA nodal artery is coming off the left circulation. So here it's coming off the circumflex coronary artery. Again, how do you recognize it as the SA nodal branch? Yeah, it's going into the intratracheal septum. It's headed towards the intratracheal septum, okay? All right, so the left coronary artery, so we have the left main that passes forward there, and then that will divide usually into the LAD and the circumflex coronary artery. So the LAD runs in the anterior interventricular groove between the right ventricle and the left ventricle. We have septal perforators that come down that supply the anterior portion of the interventricular septum, and then we have the diagonals that supply the anterior wall of the left ventricle. So the diagonals, the first one is called D1, the second one D2. Same thing with the septal perforators. The first one is S1, the second one S2. So that's the nomenclature. The left circumflex coronary artery runs in the left atrioventricular groove. And then, as you said, in about 30% of cases, you might have the SA nodal artery coming off of there. And then we have marginal branches from here supplying the lateral wall of the left ventricle. Now, this anatomy you can also make out when you're looking at coronary angiograms, conventional catheter coronary angiograms. So in the right anterior oblique view, so here you have the injection of the right coronary artery that's coming towards you here. And then here in profile, what vessel do we have here in profile?
PDA.
PDA, right, that's the right dominant system. That's the PDA down there that you have in profile. And then here in the left anterior oblique view, now you have the right coronary artery here in profile. The PDA here is shortened here as it's coming towards you in this view, okay? Same thing with the left coronary artery and the right anterior oblique view. I mean, when we inject the left main coronary artery and this right anterior oblique view here, okay? So this guy over here would be LED, right? This guy over here, circumflex. So these branches coming off the circumflex would be, yeah, those would be the obtuse marginal branches, right? And then on the left anterior oblique view, so here the LAD is coming towards you. These branches in here, what are these guys?
Perforated.
Right, those are the septal perforators. So on this view, those guys would come off medially going down into the interventricular septum. And then these guys over here would be diagonals, right? Those would be the diagonals. So this anatomy you can make out also on catheter angiogram. Now there's some variation as to the left main. You might have a long left main coronary artery, as in this case. You might have a short left main coronary artery, as in that case. Here also we have the conus branch having a separate origin there from the aorta, so you can have some slight variations here. Okay, so here we have the left main, circumflex LAD, and there is a trifurcation, so then this vessel in the middle, we call that the ramus intermedius. So in the right atrioventricular groove, this is the right coronary artery. The LAD here runs in the anterior interventricular groove, so between the right ventricle and the left ventricle. And then here we have the circumflex coronary artery that runs in the left atrioventricular groove. GCV stands for great cardiac vein, right? So those also run alongside the coronary vessels. Generally, those are larger than the coronary arteries, and also since the injection is timed for the arterial phase, usually the contrast opacification of the venous system is somewhat less than the opacification of the arteries, of the coronary arteries. If we have a trifurcation, as we see here, then that vessel in the middle, that is called the ramus intermedius. So that occurs about 20% of the time, okay? All right, so we've covered this part already, vessel going anteriorly towards the outflow tract of the right ventricle, that's the conus branch. From the right coronary artery vessel going posteriorly towards the interatrial septum, that would be the SA nodal branch. So this we have already gone over, okay? So here's nice volume rendering, right coronary artery. This guy going backwards is the SA nodal branch. This guy coming anteriorly towards the outflow tract of the right ventricle would be conus, right? And then these are the acute marginal branches. So now here we're looking at the back of the heart, okay? Vessel A, what is vessel A?
PDA?
Yeah, so the first thing to do when you're looking at these volume rendered images is orient yourself as to the cardiac chambers, okay? So this chamber is
Right ventricle?
left ventricle. Remember, you're looking posteriorly, it's a posterior view. This chamber,
Right ventricle.
right ventricle. This chamber, left atrium, this guy over here, right atrium. So we have this vessel over here that is running in the right atrioventricular groove, so what would that be? What vessel is this?
Right.
Yeah, that's the RCA, it's the right coronary artery. Remember, you're looking at a posterior view here, right? So then this would be the PDA, as you said. Vessel B, what is vessel B? Yeah, so that's a posterior left ventricular branch, so this is a dominant right coronary artery given with PDA and the posterior ventricular branch there, okay, supplying the inferior wall of the left ventricle. So on your source images, on your axial images, the PDA is way down here, kind of towards the bottom of the scan, okay, remember we're looking at the back of the heart here. This one, anatomy is a little bit variable. You don't have a well-defined PDA here. These are veins, right? So you have multiple vessels here kind of going towards the distribution of the PDA in this particular case. Now, segmentation of coronary arteries. So I don't expect you to memorize the numbers, but you should be able to designate proximal, mid, and distal. And so we'll go over that. So segmentation of the right coronary artery. The proximal right coronary artery from the origin halfway to the acute margin. Again, this was named, this segmentation nomenclature comes from catheter angiography. So from halfway to the acute margin of the heart here, this view, when you lay out the right coronary artery. That is the proximal right coronary artery. The mid-right coronary artery is from that point to the acute margin of the heart. That's the mid-coronary artery, the mid-right coronary artery. And then the distal right coronary artery is from the acute margin to the base of the heart, the rest of the right coronary artery there. So that's segmentation for the right coronary artery. For the LAD, the proximal LAD is from the origin to the first septal perforator. That is called S1. So that is the proximal LAD. The mid-LAD is from where S1 comes off to halfway to the apex of the ventricle. So that is the mid-LAD. And then the distal LAD is from that halfway point to the rest of the LAD. So that is the distal LAD. Okay. The left circumflex, usually the circumflex is a shorter vessel because most patients are right dominant. So the proximal circumflex is from the origin to the first marginal branch, so the obtuse marginal branch here. So that is the proximal left circumflex. The distal circumflex here is the remainder of the left circumflex. And it is not unusual for the obtuse marginal branch here to be larger than the remainder of the circumflex coronary artery. So in a right dominant system, the circumflex coronary artery can be pretty small here after you've had the takeoff of the larger obtuse marginal branches from the circumflex coronary artery. Sometimes you'll have an LAD that comes around and wraps around the apex, so some of it actually goes all the way to the posterior part of the left ventricle. That's called a wraparound LAD. Sometimes there can be multiple vessels supplying PDA territory instead of one well-defined PDA. So those are variants that you might come across. Here we have separate ostia for the LAD and the circumflex. So we're looking from the top down. So again, when you orient yourself as to the chambers here, this is the right ventricle here, it's the right atrium. So here's the right coronary artery. And then here you have the LAD and the circumflex having separate ostia coming off of the aorta. Okay. All right, so who wants to talk about this case? What do we have here?
Looks like it's co-dominant.
Well, again, what we want to do is we want to identify.
So it's a dominant LCA.
All right, so you want to identify the chambers first, right? So this chamber is
Left ventricle,
left ventricle, right? This chamber,
right ventricle,
this chamber,
left atrium,
this chamber.
right atrium.
Right. So what kind of view are you looking at in this case? Yeah, you'll get a posterior view. So this vessel is running in which atrioventricular groove?
Left,
Yeah. So this vessel would be,
LCS.
yeah, that's the circumflex. That's running in the left atrioventricular groove. Okay. So this vessel coming off the circumflex is
PDA,
PDA, and it's running in the posterior interventricular groove. And then you have this vessel, which is supplying the posterior wall of the left ventricle, which would be posterior left ventricular branch. So then what we are looking at is, as you said, dominant, yeah. So we're looking at a dominant left coronary artery. Notice the right coronary artery, in most cases, the right coronary artery is dominant. It's not going all the way around, right? Because it's kind of shortened, and that's usually what happens when you have a non-dominant right coronary artery. So here on the axial view, so here we have the left circumflex coming down, giving you branches to the posterior wall of the left ventricle, and then the PDA, and then you can see that a little bit better in this volume rendering from an axial kind of perspective, okay? All right, who wants to talk about this guy?
it's a co-dominant,
Okay, so here again, it's probably easiest to look at the volume rendered view here, right? So this chamber,
left ventricle,
this guy,
left atrium,
this guy,
right ventricle,
and this guy.
right
So
atrium,
again, what kind of view is this? You're
posterior,
looking posteriorly. So this groove is the
left AV group,
left AV groove. What vessel runs in the left AV groove?
left circumflex,
Left circumflex. This groove is the
right AV,
right AV groove. What vessel runs in the right AV groove?
right coronary,
Right coronary artery. This guy is,
PDA,
and it's coming off
right,
right coronary artery. This guy,
posterior, left
posterior left ventricular branch, and it's coming off circumflex. So then this is a
co-dominant,
dominant, right? You can see two vessels here, right? Two vessels, right? One coming off the right, which is the which is going to be the PDA, and then one coming off to the left, which is going to be the posterior ventricular branch, left ventricular branch. So that's codominant. Okay. Most patients are right coronary artery dominant. About 11% can be codominant, about 9% will have left-sided dominance. The dominant vessel supplies the inferior lateral wall of the left ventricle, so the dominant vessel gives you the PDA, the AV nodal branch, and the branches supplying the diaphragmatic surface of the left ventricle. It can be pretty difficult identifying the AV nodal branch, so that's why it's easiest to look for the PDA and the posterior left ventricular branches when you're trying to figure out dominance. Okay, right coronary artery dominance, so we will have then the right coronary artery supplies the PDA and the posterior left ventricular branches. Balanced right coronary ends at the PDA, and then you'll have the marginal branches coming off of the left. And then if we have left coronary artery dominance, the right coronary artery is usually short, so that's usually short. And then the left circumflex continues around the AV groove to give you the PDA and the posterior left ventricular branches. Okay? So when we have a dominant left coronary artery, circumflex comes all the way around there and gives you the posterior descending artery. And so dominant right coronary artery comes around, PDA, posterior left ventricular branches. Dominant left coronary artery, circumflex coronary artery comes around, gives you the posterior branches to the left ventricle, and then also gives you the PDA. So here's an example of a dominant left coronary artery. What is an easy way to spot the dominant vessel if you're looking at axial images?
You look for the AV grooves and see which one's larger.
Yeah, you look at the AV grooves and look for which vessel is larger, right? So if you look at the right atrioventricular groove, normally the right coronary artery in the right atrioventricular groove is larger than the circumflex coronary artery. But if you notice, the right coronary artery seems to be small in the atrioventricular groove. And then look at that circumflex coronary artery and it's larger. If you follow it all the way around, then that might be the dominant vessel. So coming down and wrapping around, coming all the way around, then to give you the circumflex, then giving you the posterior descending artery. Right, so look in the atrioventricular grooves. That's a very fast way of determining which is the dominant vessel. Okay, and then we've talked about codominance already, where you have the PDA coming off the right and the posterior left ventricular branches coming off the left. Right, so in the codominant system, as we see, you'll have two vessels back there. Right, one supplying one from the left side, one from the right side. You'll have PDA coming from the right, posterior left ventricular branches coming from the left. Okay, so the arrow is pointing to this vessel right here. There it is. What is that guy?
AV nodal.
Well, AV nodal is a tough vessel to see, right? So this guy is the PDA here, okay? And then this guy is continuing, right?
So maybe it's the posterior left ventricular branch.
Yeah, so that's posterior left ventricular branch. What is this tiny guy?
That's the AV nodal.
That's the AV nodal. Okay, so the AV nodal is a very small vessel, and usually it comes off where you have this U-turn here, right, where you have this turn. So it tends to be a tiny vessel. It's hard to identify. You don't always definitely see it, right? So it's a tough vessel to see. That is the AV nodal branch, okay? All right, so here we're looking at a posterior view. What's different this time? What do we have labeled?
Venous system.
Yeah, so now we have the venous system that's labeled. So A is coronary sinus, B,
Great cardiac vein.
great cardiac vein, C, what is C?
Posterior interventricular.
Yeah, posterior interventricular vein or middle cardiac vein. Okay? Posterior interventricular vein or middle cardiac vein. So these are the coronary veins. So we have the coronary sinus that's going to receive the venous drainage. You can have a vessel, a vein, traveling in the anterior interventricular groove. That's the anterior interventricular vein. That will run alongside the LAD. Posterior interventricular vein runs alongside the PDA. This is the great cardiac vein, which then runs into the coronary sinus, right? So we've talked about the coronary sinus and the BC valve before, talked about the great cardiac vein, which is the continuation of the coronary sinus there in that in that groove, in the left atrial ventricular groove. Okay. There are other veins also, and these can be important if somebody has left bundle branch block. Remember that to pace the left ventricle, they will pace a wire through the coronary sinus going into a coronary vein alongside the left ventricle. So then that's how they will pace if they need to do biventricular pacing. They can pace the right ventricle through a lead that is actually within the right ventricle. But to pace the left ventricle separately, if there's left bundle branch block, the lead would have to go through the coronary sinus and then into a coronary vein alongside the left ventricle. Okay, so which vein is this?
Anterior interventricular.
Yeah, it's easy to try to identify the coronary artery. So which coronary artery is that?
LAD.
LAD, right. So the vein alongside the LAD is the anterior interventricular vein, right. So what artery is this?
Left circumflex.
Yeah, that would be the left circumflex. It's running in the left atrial ventricular groove. So you said this vessel is?
Great cardiac vein.
That's the great cardiac vein. Okay. So that runs in that left atrial ventricular groove. So this is what a nice normal coronary CTA looks like. We can have these nice curved reformats that lay out the vessel very nicely. So here's the right coronary artery as it goes around there. Here is the LAD, kind of wraps around a little bit. Here's the circumflex here, going around the left. Okay. So let's talk about some coronary anomalies. So what vessel are we looking at here?
LAD.
Yeah, so we're looking at the LAD, okay? And what do we have?
Myocardial bridge.
Okay, so this is a myocardial bridge. How did you identify that as a bridge?
Goes within the muscular.
Yes, so it dives down into the myocardium, right? So it's going into the myocardium. So what's the significance of a myocardial bridge?
It can cause chest pain.
Yeah, so in patients who are asymptomatic, who are symptomatic, sometimes this can be a cause of the vessel might get some obstruction as it goes through here during systole, right? It can get squeezed. The most common location for a myocardial bridge? Anybody?
Anterior wall.
Well, right where you see here in the mid-LAD.
Oh.
So the mid-LAD is the most common location. In most cases, are these significant or not significant when we see them on coronary CTA?
Not significant.
Yeah, in most cases, these are incidental findings on coronary CTA because they're much easier to see on coronary CTA than they are with angiography. But there might be cases, and we'll talk about the things that you look for, where it might be a significant finding. Okay?
Could you do a bypass if you were symptomatic?
If it's symptomatic, they unroof it. Okay. So on angiography, what they look for is what's called milking of the vessel. So on systole, you can see that the vessel narrows, and that's what they look for to make this diagnosis on angiography. Okay. You can do the same thing on CT, but to do it on CT, what must you have done?
Retrospective.
Yeah, you have to do retrospective gating and have images in systole. And if you do that, you might demonstrate narrowing of the vessel here. Usually, we don't have images in systole. Usually, we're doing the gated scanning, prospective gating, and we have diastolic images. Okay. So when it narrows during systole, then it might be an important finding. So most bridges that we see are superficial bridges. So in most cases, when we see them on coronary CT, they're not significant. But if there is a deep bridge, and if it dives more than 3 millimeters into the myocardium, as you can see here, then it might be significant and it might be important, especially if the patient is symptomatic. Okay, and then it would also be important to do study stress testing, et cetera, for ischemia. Is there ischemia along the course of that vessel to make sure that that's the culprit lesion? Okay. Most cases on CT, it's incidental finding, but there can be cases when it's important. This is what we look for. So deep myocardial bridge, if it dives deep into the myocardium, that's certainly something that has to be looked at. Okay. So what's the, what vessel is this guy?
Right,
Yeah, so that's the right coronary artery. Okay. And so this guy over here,
left coronary LAD.
yeah, so it's going into the LAD over here. What do we have in this case?
They share a common origin.
Okay, and what's important about this? So if you have an abnormal origin of a coronary vessel, right, you have to evaluate the course of that vessel, right? So what's important about the course? What are important things about the course that we need to
Oh,
determine?
if it's between the great vessels,
So if it's between what two vessels?
aorta and pulmonary
Yeah,
trunk,
if it's going between the aorta and the pulmonary artery, we call that course
malignant.
intra-arterial.
Okay.
It can be a malignant course, right? Okay. So what do we have here?
Interarterial.
Yeah, this is an intra-arterial course, right? So this vessel is traveling here between the pulmonary artery here and the aorta, so that is an intra-arterial course. So that can be potentially malignant. Okay, it can be associated with ischemia. So left coronary artery coming from the right, this one is taking an intra-arterial course, traveling between the pulmonary artery and the aorta. So it can get squeezed there. So aberrant coronary origins. So the most common is to have the circumflexion of the right coronary artery. Fortunately, most of these will take a retroaortic course, which is considered a benign course. Okay? But that's the one clinically that you might see the most. So you want to be able to recognize that and recognize that if it is going behind the aorta, that is a benign course. So when you have a vessel taking an anomalous course, the important thing to determine, is it going between the aorta and the pulmonary artery? Is it taking an intra-arterial course, or is it taking a more benign course? A retroaortic course going behind the aorta is a benign course. The intra-arterial course really is the only malignant course that you have to be concerned about. So you can have right coming off the left or left coming off the right. The important thing is to determine the course. How is it traveling? Is it going between the pulmonary artery and the aorta? So those intra-arterial courses are potentially malignant courses. So whether it's left coming off the right or whether it's right coming off the left, you want to look at its course. Is it traveling between the aorta and the pulmonary artery? And that those courses, if it is an intra-arterial course, it's considered a potentially malignant course. Okay, what about this case here? What do we have?
Benign course.
What vessel is the anomalous vessel?
So like it's
Left
Oh,
knee.
So,
LCX.
yeah, so how do you figure this out? First, look where so this vessel looked like it's doing something funny, right? So right away, okay, there's something wrong with this guy. It's doing something it's not supposed to do. Look where it goes, right? So this vessel winds up here, right? So where is that? That's between what chambers?
Left atrium.
Yeah, so that's headed towards that's headed towards right, the left atrioventricular groove. So what vessel would that be?
Left,
No, left atrioventricular groove is the
left circumflex.
circumflex, right. So where is it going? So that's going to be the circumflex. And in this case, how it's coming off the right coronary artery, right? So that's an anomalous origin. And is it taking an intra-arterial course or some other course?
Some other course.
Some other course, right. And so how do we describe this course?
Retroaortic.
Retroaortic, right. So it's going behind the aorta, so it's taking a retroaortic course. So benign or malignant?
Benign.
Benign, right. So we have a circumflex here that's taking a benign course. It's going behind the aorta, right? So it's a circumflex taking retroaortic course. So that is a benign course. That is not associated with obstruction and ischemia.
Dr. Malgin,
Yeah.
on the previous contrasted CT, was there a way to see prior, even before this one? Lots of slides back. Sorry, I didn't ask earlier. This one, how
Yeah.
would you be able to tell which cusp that's coming off of, or?
Well, it looks like it looks like it shares a common origin with the right, so I'd say it's coming off the right
Okay.
cusp there, okay? Okay, so here we're looking from the top down, and again, you want to orient yourself to the chamber. So when you're looking from the top down, this would be the right atrium, that would be the left atrium, you're looking from the top down here. So that's the aorta, that's the pulmonary artery. It's this vessel traveling here in the left atrioventricular groove is the circumflex coronary artery. That's coming off the other side there, but it's going behind the aorta. It's taking a retroaortic course. Okay. Notice the LAD has a completely separate origin. And then here you have the right coronary artery, so it's kind of sharing an origin. Another course a vessel, an anomalous vessel can take is actually to go anterior to the pulmonary artery. So there's the left coronary artery coming off the right, going anterior to the pulmonary artery. So that is called a pre-pulmonic course. So that is also a benign course. So if the vessel goes anterior to the pulmonary artery, that is also a benign course. What do we have here?
Aberrant right coronary artery off of the cusp of the left or off
Yes.
the left?
Yeah, it's not coming off the left vessel, but it's coming off
The cusp.
the left cusp, yeah. And what about the course? That view on the right is very helpful.
Okay.
Yeah, it says, how do you know it's interarterial? Can you see the anomalous vessel there on that view? Do you see it?
Yeah.
Yeah, between the.
It's right there. This guy here, okay?
Oh.
Right there, there it is. So this guy is aorta, right? That's the ventricle, that's left ventricle, that's the aorta. This guy is pulmonary artery. This view, being able to reformat it into this view can be very helpful, all right? So what you want to do is you want to be able to reformat it to kind of a sagittal view where you can see the aorta and the pulmonary artery, and you can see the vessel. Is the vessel actually between those two arteries, those two great vessels? And if we can demonstrate that, then that is an interarterial course. And then here too, we suspect that it's going to be interarterial, right? Because this guy is, this guy over here,
Aorta.
aorta. And then this guy is pulmonary artery. You can see the pulmonic valve here, see it? So this portion of it right here is between the pulmonary artery and the aorta, okay? So that's the right coronary artery from the left side is taking an interarterial course. Right? Here's a nice volume rendering showing you the vessel. Here's the aorta, here's the pulmonary artery. There it is going across, taking that interarterial course, right coronary artery from the left. Okay. Again, we can look at it. If you've done retrospective gating, you can look to see what happens to the vessel in systole and diastole. Most cases, though, we don't have this information, but you can demonstrate narrowing of the vessel sometimes like that in systole. So what are the features that we look for? The important thing is, so anomalous left coronary artery from the right taking an interarterial course, that tends to be more dangerous than the anomalous right taking an interarterial course. Okay, but for these vessels, whenever they have an anomalous origin, things that we look for: slit-like orifice. So if the origin of the vessel is narrowed, acute angulation of at the origin. So if it kind of bends abruptly like that, and an intramural course. Is it wrapping around the ascending aorta like this, right? Then in that case, it might be traveling actually within the wall of the vessel, okay? And all of those things are considered high-risk features of that are associated with ischemia. So those are additional things that we look for whenever we have an anomalous origin of a vessel. The current thinking now is if you don't have risk, if you don't see risk factors like that, if the patient is relatively asymptomatic, if you have an anomalous right from the left, and the patient is not symptomatic from it, and you can't demonstrate that there's ischemia along the course of the vessel, they tend to leave that alone, even though it's taking an interarterial course. Okay, so it's kind of in flux as to what is the actual treatment for these things. But as far as the boards are concerned, if you have an interarterial course, that is a potentially malignant course. That's what you want to be able to identify. And then know what the high-risk features are. Okay? One other twist on this, the so-called high versus low interarterial course. And again, we're talking about the right coronary artery coming off the left. So if the origin of the vessel here is above the pulmonic valve, that's considered a high interarterial course. If the origin is below the pulmonic valve, that's considered a low interarterial course. These tend to be more dangerous, the high interarterial course. So if the origin is above the pulmonic valve, and you can see it's more likely to take an interarterial course there, as opposed to the origin being below the pulmonic valve, low interarterial course. These tend to be worse. So in this study where they compared, you could see the patients who had problems with the high interarterial course versus those patients with the low interarterial course, right? So the high interarterial course of the aberrant right from the left in this study has been shown to be more concerning. Right? But again, as far as we're concerned for the boards, interarterial course is the malignant course that you want to be able to identify. Okay, so time for, we have a few more. So, what are we looking at here?
Left main off of the right retroaortic course.
Yeah, so we have we have a vessel that's going to the left side, right? So we have this vessel that's going to the left side. I'm not sure exactly what vessel is. You need to see all the others, where is the left main? Is this a circumflex? Is this the entire left coronary artery, right? You really can't tell that from this single image that I've given you. You might suspect it looks like there's some vessels here. Maybe this is the circumflex, right? So it's going behind the aorta. And then here on this view, this guy is aorta, this guy.
Pulmonary outflow tract.
Right. This is pulmonary artery, yeah, right here. And so there's the anomalous vessel. This is the left atrium. So you can see the vessel is behind the aorta. So it's a retroaortic course. So whatever it is, it's a benign course. And in this case, it turns out to be the circumflex coronary artery, taking the retroaortic course of the benign course. Okay. What about this guy?
LAD taking off of the right coronary,
Yeah.
and it's going into the right ventricle. Oh, I forgot what this is
So
called.
is this a benign course or is this a malignant course?
Benign.
Yeah, this is a benign course. It's not interarterial, right? So if we, again, look at this sagittal reconstruction, here's what am I pointing to here? What is this guy?
Aortic valve,
That's the aortic valve. This guy over here,
pulmonary artery.
pulmonary artery. The vessel is down here, right? So it's going through the interventricular septum. So this is called a transeptal course, right? So even though you might think, oh, wow, it looks like it's going between the aorta and the pulmonary artery, it's actually going through the myocardium here, right? So it's not interarterial. So this is also considered a benign course. A transeptal course is also considered a benign course. That is a transeptal LAD, not associated with ischemia. Okay? So transeptal LAD, that is also considered benign. So what do you need to know? Prepulmonic course is okay. Transeptal course is okay. Retroaortic course is okay. Only when the vessel is going between the aorta and the pulmonary artery, that is an interarterial course. That is the one that is potentially malignant. Right? So that's the one that we want to be able to identify. Okay? Okay, so continuing with our discussion of coronary arteries, we have a chest radiograph here in a young woman who's having chest pain, and we see cardiomegaly, and we have a CT scan here. We do a coronary artery CT scan. We see that the coronary arteries are dilated. So my question to any of you guys out there in virtual land, what are some reasons why coronary arteries might be dilated like this? What could do this?
You can have a fistula.
So coronary arteriovenous fistula, right? That could give you dilated coronary arteries. Anything else?
She's young, so maybe she likes drugs. Like
So,
cocaine.
yeah, well, those are aneurysms, right? So aneurysms of the coronary arteries can be associated with drug abuse. Anything else that can give you dilated coronary arteries?
Vasculitis.
Yeah, sure. Vasculitis, right. So vasculitis could also be associated with dilated coronary arteries. So in this patient here, we have some images from the cardiac CT scan. And
So it looks like the left coronary artery is dilated, and it looks like it may be coming off of the pulmonary artery.
yeah, so this guy is the aorta. We can see that that's connected to the left ventricle. This is the pulmonary artery. So we have a coronary artery here that's originating from the pulmonary artery. And here we can see that this is the left main coronary artery here, originating from the pulmonary artery here, right? So what is this called?
Al Kappa.
Al Kappa, or anomalous left coronary artery from pulmonary artery, right? So in this condition, what happens is, because of the low pressure from the origin of the coronary artery from the pulmonary artery, the flow is actually reversed, and the patient develops collaterals from the right circulation to the left, so that's why all the coronary arteries dilate. The flow is reversed in the left coronary artery traveling to the pulmonary artery, and this is what can result in ischemia to the parts of the myocardium, in this case supplied by the left coronary artery. You see a nice collateral here actually going across. What do we call this?
Something circular, or
Well, so what vessel is that that's going across?
is that
So the circle of Vincennes, right? So this is the conus branch. Right. So the conus branch here, you can see that, the circle of Vincennes in this case, acting as a collateral. So this is also called Bland-White-Garland syndrome, or Al Kappa. Depending on the status of the collateral circulation, it can determine when the symptoms present. So if the collaterals are not very well formed, and you can have myocardial infarctions very early on in life, and we've talked about already the reverse flow here within the left coronary circulation associated with this. So here's a conventional angiogram where you inject the right coronary artery. You can see that it's dilated, but you can see here all the collaterals from the right coronary artery to the left, and then that reverse flow in the left coronary artery dumping into the pulmonary artery way out there. So origin left coronary artery from pulmonary artery. Here it's illustrated, big heart. See the collaterals, reverse flow in the left coronary artery dumping into the pulmonary artery. And then, as we've said, depending on the status of the collaterals, if they're not well formed, this can present in infancy. If the collaterals are well formed, then it might be clinically silent until later on in adulthood. But these patients can present with ischemic symptoms leading to ventricular dysrhythmias, ischemic cardiomyopathy, and if the heart gets big, of course, mitral insufficiency. This can result in sudden death in up to 80 to 90% of cases. So another example here, you can see the collaterals nicely demonstrated here to the right coronary artery, to the left coronary artery, and then the left coronary artery originating from the pulmonary artery. Okay. And then in this example, we also see the collaterals. Notice on MRI, the diffuse subendocardial enhancement because of subendocardial infarct from the ischemia of the left ventricle as a result of the reverse flow within the left coronary circulation. Okay, so here's a patient who has a catheter angiogram. What vessel is injected here?
left main.
Yeah, so the left main coronary artery receives the injection. Is there anything that looks peculiar?
There's like a vessel that's going cephalad.
Right, so there's this funny looking vessel, right, that's coming up here. And then the question is, where is the contrast going, right? It's a very peculiar appearance. Where is that contrast going? So we're going to be interested in looking at what vessel here?
That's LAD.
LAD, okay. So here we have CT of the coronary arteries.
There's a vessel that's connecting to the pulmonary artery.
Yeah, so here is the left anterior descending coronary artery, and you can see that there's this branch coming off of it that is connecting to the pulmonary artery. Okay? So as opposed to Al Capo, where you have the entire coronary artery originating from the pulmonary artery, here there's just a branch of the vessel that connects to the pulmonary artery. And of course, again, because of the pressure gradient, because of the low pressure in the pulmonary artery, that's going to draw all the flow through there. So this is another example of a coronary arteriovenous fistula that can result in ischemia from taking the flow away from that vessel, taking it to the pulmonary artery. So here you can see the tortuous vessel here connecting to the pulmonary artery. Okay. This patient has a very dilated right coronary artery. We can see it here. Okay. So why is this right coronary artery dilated in this case?
It looks like it's abnormally connecting to the coronary sinus.
Yeah, so down here you can see the coronary sinus. So the coronary artery comes down and connects to the coronary sinus. Again, another form of an arteriovenous fistula. So fistula from the right coronary artery here to the coronary sinus. So coronary arteriovenous fistula, what are they? What are the common sites? So it's a connection from the coronary artery to a coronary vein, coronary sinus. Could also be right atrium, right ventricle, or pulmonary artery. Most commonly right coronary artery to right atrium or right ventricle. The involved coronary artery is usually dilated and tortuous, and there is a small left to right shunt, but that's not the physiologically important part. The important part is the ischemia that can result because the blood flow is drawn away from the coronary circulation. So most will originate from the right. You can also have some from the left. A very small percent can be bilateral. If it drains to a chamber, it's called a coronary cameral fistula, because these can also drain to the right ventricle, right, or the right atrium. And if it drains to a vessel, then it's a coronary arteriovenous fistula. So it can drain to the pulmonary artery or the coronary sinus. So here's a left circumflex coronary artery that is markedly dilated, and then on this curved reconstruction, you can see it's connecting to the right atrium. And so again, because of the pressure gradient, the flow will preferentially be towards the right atrium in that case. Here you can see the dilated tortuous vessel coming down, and then the flow directed towards the right atrium. So these usually present in early adulthood, can present with myocardial ischemia, coronary steal, CHF, infective endocarditis, arrhythmias, rarely rupture. Usually you'll see a dilated coronary artery. It's important to follow it to the end of the vessel to see where it goes. It's dilated. So when we see dilated coronary arteries like that, we want to follow them. We want to see where they're going. And here's a coronary fistula here from the right coronary artery going all the way to the right atrium there. Okay? So that when we see a dilated coronary artery like that, we want to think about coronary arteriovenous fistula. Where is that vessel going? So here we have a young woman with chest pain, and we have some volume rendered views here. What vessel is this?
Left main.
Left main, this guy,
LAD.
LAD, this guy over here, circumflex, this guy here. Yeah, you might call that a ramus intermedius. This guy over here,
RCM.
right? That's the right coronary artery. So what looks abnormal in this case?
A couple aneurysms.
So we see an aneurysm, where is that coming off?
LAD,
Yeah, it's LAD near the,
D1.
yeah, near D1. And then what about the right coronary artery?
That's right where the acute marginal branch is.
Yeah, so right here, we also have an aneurysm from the right coronary artery. So here we have a young woman with coronary artery aneurysms. You mentioned some things earlier that would be in the differential for coronary artery aneurysms. And the most common cause of coronary artery aneurysms, of course, is atherosclerosis, but you wouldn't expect that in a young person like this. You mentioned drugs like cocaine that can cause coronary artery aneurysms, and you also mentioned vasculitis, which can be a cause of coronary artery aneurysm. So in a young patient, when we see coronary artery aneurysms, what are we supposed to think about? Yeah, so Kawasaki's, right? So here's the right coronary artery here. We can see the aneurysm. Now, on the short axis view, can you determine why the patient has chest pain?
There's a subendocardial infarct.
Yeah, so there's a subendocardial either perfusion defect or an infarct. You want to know, what happens to that, right? So if it's an infarct, why would this patient have an infarct there? Well, what's a complication of a coronary artery aneurysm? What? Yeah. So emboli. So you can have small thrombi that form in there that can embolize distally and can result in small areas of infarction, as in this case. Okay? So if we see coronary artery aneurysms in young people, there's another nice example there, the right coronary artery, Kawasaki's disease. And so this can present usually in younger patients, especially children, with fever, lymphadenopathy, rash, coronary artery aneurysms. Depending on their size, that can determine the natural history. Aneurysms less than 4 millimeters usually regress. Aneurysms greater than 8 millimeters can progress to obstruction or stenosis. And so if we have a young person with coronary artery aneurysms, especially multiple coronary artery aneurysms, we want to make sure to think about Kawasaki's disease. So we've talked about the definition of an aneurysm, dilatation 50% or greater than the preceding normal artery, and we've talked about the differential. The most common cause in the United States is atherosclerosis, but other things in your differential, vasculitis, mycotic aneurysms, drug use, might also be congenital. That's unusual. Now, coronary artery disease, right? So, of course, this is a major cause of death all over the world. 50% of fatalities from coronary artery disease have no prior symptoms, and that's because in most cases, the acute coronary syndrome occurs from a rupture of a plaque. So you can have a plaque within the wall of a vessel, not causing much in the way of stenosis of the vessel, but when the plaque ruptures, then you get thrombosis of the coronary artery, and then the patient develops an acute myocardial infarction. So that's called the vulnerable plaque hypothesis. So you can have these lipid-filled plaques along the arterial wall of the coronary artery. They have a fibrous cap. When the cap ruptures, then the contents of it cause thrombosis there within the coronary artery, and you get an acute myocardial infarction. So rupture of soft plaque is thought to be the most common cause of myocardial infarction. The natural history of plaques, so as these plaques grow within the wall, they can get very large without causing much in the way of obstruction. As they mature then they might develop calcification, and that's when you might develop narrowing of the vessel, stable angina. That occurs later on in the course of the development of the plaque. But when the plaque is mostly lipid, that's when it's the most dangerous. That's when it can rupture in patients who are otherwise asymptomatic. Also, with plaques, you can get positive remodeling, meaning that the plaque can grow away from the lumen without causing much obstruction of the lumen. So you can have sizable plaques along the arterial wall without much narrowing of the lumen. Remember, when they do catheter angiography, they're just looking at the lumen. They can't really assess how much plaque there is within the wall of the vessel. As far as the grading of stenosis, when you're looking at coronary CTAs, make sure that you have this grading scheme in mind, so it correlates with a CAD-RAD score, just like we have lung RAD score and BI-RADs for mammography. We also have CAD-RADs for judging coronary stenosis. So a CAD-RADS 1 is associated with less than 25% stenosis, mild stenosis, which is a 2, 25 to 49%, moderate 50 to 69%, and severe 70 to 99%. So when we're evaluating coronary CTAs and evaluating stenosis, we think of it in terms of these ranges, and we'll get back to the CAD-RAD scoring system and what to do with the different categories a little bit later on. It's important to realize that stenosis of about 80% or greater is necessary before you actually have symptoms at rest. So you can have pretty significant stenosis when it's less than 80%, and the flow, they will not be flow limiting, and it's not until you stress the patient that these lower grades of stenosis that you will see the flow limitations. Okay. Most stenoses occur in the proximal portions of the arteries. I've given you the distribution of significant stenoses according to the literature. We've talked about the circle of Vincennes, right? Kugel's artery also we'll mention intercoronary collateral circulations. Basically, you can have collaterals from the LAD and the PDA, so wherever the vessels come close to each other over the apex of the heart, through the interventricular septum, you can also have collaterals. We've talked about the circle of Vincennes, which is the collateral from the conus branch of the right coronary artery to the LAD. So that can also give you collaterals. And then the other named collateral is Kugel's artery. This is not a collateral that we can actually see on coronary CTA, but it's any collateral that connects to the AV node artery. So that's been called Kugel's artery. So we've talked about, here's the circle of Vincennes, in our case about kappa that we discussed earlier. Let's talk about bypass grafts. The two major types of coronary bypass grafts are
Saphenous
vein bypass and
internal memory.
internal memory. So what are the advantages and disadvantages of each type?
The saphenous vein is larger in the lumen size.
Yeah, so because the saphenous vein graft has a larger lumen size, it can have a higher flow rate. Okay. The internal mammary artery is smaller than the saphenous vein, so the flow rate is somewhat less, right? So that would be an advantage of a saphenous vein graft. What's another advantage of a saphenous vein graft?
It's longer.
More options to where to bypass to. So you can bypass just about to any vessel with a saphenous vein graft. With the internal mammary artery graft, because the proximal end has to still be attached to the subclavian artery, there are some limitations as to where you can attach it to. The most common is the left internal mammary artery attached to the LAD. So what is the advantage then of internal mammary artery graft opposed to saphenous vein graft? Long-term patency rate, yeah. So the internal mammary artery grafts have a higher long-term patency rate. So internal mammary artery grafts, one end starts at the subclavian artery. They dissect the rest of it off of the sternum. And then the most common here is left internal mammary artery attached to the LAD. Okay, this flow rate is slower than a saphenous vein graft, but the patency rate is higher. It doesn't tend to develop as much intimal hyperplasia as you can get with saphenous vein grafts. So the saphenous vein graft is attached to the ascending aorta here at one end, and then the other end is attached to whatever vessel that you want to bypass to. Okay. So saphenous vein grafts, easy to tell. You can see they're attached to the ascending aorta, and then the rest of it goes to the coronary artery. The internal mammary artery graft is attached. It starts at the subclavian artery and then comes down and then goes to the coronary artery that it is attached to. Right. So here's a right internal mammary artery graft going to the LAD. Here it's laid out for you nicely on the curved reformatted view. So here's a saphenous vein graft. What's wrong with it? Yeah, it's thrombosed, right? So you can see the thrombus there within the saphenous vein graft. Okay. More examples of thrombus and saphenous vein grafts. So one of the easiest ways to evaluate grafts, of course, bypass grafts now is with CTA, but you have to remember that you have to start the acquisition higher, especially with an internal mammary artery graft. You have to start above the level of the subclavian artery because you want to cover the entire course of the graft. This patient has a history of coronary artery bypass graft. What's wrong and what is the sign?
There's an outpouching of it's in
Yeah, so this outpouching, right? What is the significance of this outpouching?
It could be where they grafted,
What kind of graft?
so it's going to be saphenous vein.
Yeah, saphenous vein graft. So that marks where the saphenous vein graft, where there was a saphenous vein graft, and now it's occluded, right? So this sign is called
The nubbin.
the nubbin sign, right? So this is a sign of an occluded saphenous vein graft. Remember, you only see the graft well if there's contrast in it. But if the graft is completely thrombosed, it can fibrose down. It may be very difficult to see in its thrombosed condition. But a sign that there was a saphenous vein graft here is the nubbin sign. That's the proximal portion of the saphenous vein graft. Right? So that's the nubbin sign, and it's an indication of occlusion of a saphenous vein graft. This patient also has an internal mammary artery graft there. Okay. So, axial image from a CT scan. Anybody except Lamb see anything wrong here?
Dilated saphenous vein graft.
So this guy is what?
Left atrium,
This guy,
right atrium,
this guy,
ventricle,
this guy,
and ventricle,
this guy.
aorta.
Right. So there's this vascular structure here that you need to explain, right? And how do you know the patient's had a bypass graft?
Sternotomy wires.
They're sternotomy wires, right? So this patient has had a sternotomy. So anytime you see a dilated vessel along the course of what might have been a bypass or where a bypass would be, you need to think about an aneurysm. This is 6 weeks later. So this is actually a pseudoaneurysm of a saphenous vein bypass graft. Okay? So it's a saphenous vein graft pseudoaneurysm. So these can occur along the course of bypass grafts, either at the proximal or distal anastomosis. It's somewhat more common with saphenous vein grafts, but the important thing is if you see a dilated vessel anywhere along the course of what might have been a graft, you need to think about aneurysm or pseudoaneurysm of the graft. So some indications, other indications for coronary CTA, if the patient requires a recabbage, requires redo of the cabbage, sometimes these internal mammary artery grafts can become adherent to the sternum. And so you don't want to do a median sternotomy in this patient because you would be cutting into the graft. So to determine the course of the graft and the status of these bypasses, then you might do coronary CTA, and that might make a difference in terms of the surgical approach